So I'm going to stick to the basics today, and what I'm going to talk about is going beyond the horizon, MRI spectroscopy. The first thing I want to tell you is that the difference between a normal MRI and a functional MRI is, in all the MRIs we interpret images, but in functional MRI we acquire the data, we sit with the data, and then we have to work on it. So that is the functional MRI aspect of it. So MR spectroscopy, the technique of proton magnetic resonance spectroscopy, usually shortened to MRS, allows tissue to be interrogated for the presence and concentration of various biochemical metabolites. Now it is complementary to the MRI imaging and must be interpreted along with it. So today our target is to answer this question at the end of this session. Okay, MRS utilizes the fact that protons in each metabolite will have a slightly different Lambda frequency depending on the electron surrounding it. The frequencies of the return signal from the metabolite are plotted in units of parts per million depending on their chemical shift from the Lambda frequency along with the strength of signal intensity, that is their concentration. So what we do is we make a graph. Now MR spectroscopy provides a measure of brain chemistry. The most common nuclei that are used are proton, sodium and phosphorus. So the proton spectroscopy is easier to perform and provides much higher signal to noise ratio than the sodium or the phosphorus. MRI homogeneity is 0.5 ppm, whereas MRS homogeneity is 0.1 ppm. The important difference between an imaging sequence and a spectroscopy sequence is that for spectroscopy, a readout gradient is not used during the time the RF coil is receiving the signal from the person or object being examined. So as we can see here, whenever the person is put in RF gradient, there is excitation, and in imaging there is a readout gradient that is switched on. But in spectroscopy, the readout gradient is switched off. So what is the basic principle of MRS? The distribution of electrons within an atom cause protons in the nuclei of different molecules to experience a slightly different magnetic field, which leads to different resonant frequencies, which in turn return a slightly different signal, which is called as chemical shift. So this chemical shift determines the metabolic peaks, which are expressed in parts per million. So as we can see here, in imaging, the signal comes from water protons. But in spectroscopy, the signal is coming from protons in other chemical environments. So MR spectroscopy is conducted on the same machine as a conventional MRI with added softwares, and it can be performed within 10 to 15 minutes. Now a series of sequences are added onto the conventional MRI to measure the chemical metabolism of a suspected lesion. Now there are several different metabolites or products of metabolism that can be measured to differentiate between radiologically similar looking lesions. Now MRS requires data interpretation and should always be correlated with the MRI images before making the final diagnosis. Now if all the signals were used for MRS, the fat and water peaks would be huge, and this would make the other metabolite peaks invisible. So fat and water are suppressed. Now if water is not suppressed, the graph would look like this. Now water resonates at 4.7 ppm and it is present in 10,000 times higher in concentration. So water suppression is a part of any MRS sequence, either by inversion recovery or by chest techniques. Now what is chest technique? A chest pulse selectively rotates water magnetization into the transverse plane, where it is immediately dephased by application of strong spoiler gradient. So this is done before we put the spectroscopy sequences. Now let's talk about what is short T, what is intermediate T, what is long T. Now this is the induced voltage from the recoiling of the protons which have been magnetized. So as we can see, if we acquire the data within 20 to 35 milliseconds, what we will get is we will get a lot of peaks. All the metabolites will be shown, and even those metabolites which have a very short relaxation time, even they will be shown. Now intermediate and long T, what we can see is after some time there is the induced voltage is less, and only metabolites with very high concentration would be seen here. So the question is, now why do we need this kind of a long T when the metabolite concentration is very less? Well, the answer is that at this time, at intermediate and long T, the graphs what we get is of the metabolites which are very high in concentration, and when we see the graph, these are the graphs that we see. So intermediate and long T gives us a better we can see them better. The baseline is very clearly defined. Only metabolite peaks which have a very high concentration can be seen. Now you will ask me what is important, short T image or a long T image? So the answer is both are equally important. Why? Because here we can see a lot of more metabolites than what we can see here. Now many sequences can be used for spectroscopy: steam, press, ISIs or chemical shift imaging. The first three are for single voxel MRS, and the chemical shift imaging is used in multivoxel spectroscopy. Now let's talk about steam and press. Steam is stimulated echo acquisition mode, where we use 390-degree pulses and it generates a stimulated echo. In press, we apply a 90-degree pulse and 220-degree pulses in 3 orthogonal planes, and it generates a spin echo signal. As we can see, the press gives us a data which is almost twice as good as the steam. In MRSI, what we do is we put phase encoding gradients and we put a grid. So in the grid, each square gives us the chemical composition of the metabolites. So this leads us to two forms. One is single voxel MRS and one is multivoxel MRS. Now single voxel is less advanced. There is a problem of volume averaging. Now what is volume averaging? Let us say the lesion is very small and our voxel box is big. So it will acquire data from the whole box, and it will show it to be a normal structure. So we have to be very careful about how we are putting the box on the lesion. Now it has smaller area of coverage, it is single voxel, it is a very shorter acquisition time of 6 minutes, and it is used for histologically simpler lesions. Similarly, multivoxel is more technically advanced, multiple boxes, we put a grid and we can see all the metabolites. Now grid shifting is also possible and larger volume of coverage is there. The only thing is it has long acquisition time of almost 12 minutes. Now this is a single voxel and multivoxel. As we can see, we have placed the box over the enhancing part of the lesion and we are getting the graph from it. In multivoxel, we can do acquisition from the normal brain tissue, from the enhancing part and the necrotic part in one go. So as a general rule, the single voxel short TE technique is used to make the initial diagnosis. Multivoxel long TE techniques are used to further characterize different regions of the mass and to assess brain parenchyma around or adjacent to the mass. Multivoxel long TE techniques are also used to assess the response to therapy and to search for the tumor recurrence. Now, always we do it in our institution, we do the single voxel first and then we do the multivoxel. So MRI acquisition steps are patient positioning, global shimming, then we apply water suppression, then MRS data collection is done, data is processed and displayed, and if we are plotting a graph, so there has to be a 0 point. So 0 point of the spectrum is given by tetramethylsilane or TMS, and data interpretation is done. Now let's talk about metabolite peaks. It is a time to echo that conditions the number of measurable metabolites in long T and short T. Now there are 3 metabolites that I really want you to know, which I have marked. The first one is Na, which resonates at 2 ppm, creatine, which resonates at 3 ppm, and choline, which resonates at 3.2 ppm. Now these 3 metabolites are present in very high concentration and they will be seen both with the long T and the short T. The other metabolites, lipids at 0.9 and 1.3 ppm, lactate, alanine, glutamine, glutamate complex, and MI peaks, they will be only seen with the short T. There are some less common metabolites which are also important, like acetate, succinate and taurine. Now this is the normal graph that we acquire. Now this one is the Na peak. Always remember the right side, it is present on the right side of the the graph, and it is the towering peak. Now NAA, the peak is the highest peak. The creatine peak will always be constant, which is present at 3 ppm, and choline peak will be present at 3.2 ppm. Now MI peak will be at around 3.5, and we have lipid and lactate, lipid at 0.9 ppm, lactate at 1.3 ppm. A good quality spectrum should present a flat horizontal baseline with distinct narrow peak. Now, there is age variation also seen. In newborns, there is low Na, high choline and high Mi level seen. Now, there is gradual increase in Na, which reflects the brain maturation and correlates with myelination. Now, these metabolites approach adult pattern by 1 to 2 years and are constant by the age of 4 years. Now, in elderly, we have elevated choline, elevated creatine and diminished Na. Now, what is Hunter's angle? Hunter's angle is a term coined by neurosurgeon C. Hunter Sheldon. He placed this comb on the spectrum at approximately 45 degrees angle and connected all the peaks. Now, if the angle in the peaks roughly corresponded to 45 degree angle, the curve was considered probably normal. Now, this is the kind of graph that you see. Now, this is a very good visual method of assessment, it was made by the steam spectra earlier. So, it is actually unreliable, but then at the same time, you can still use it for the viewing. Now, this is a Mi peak, this is a choline peak, this is a creatine peak, Na peak. Now, all these metabolites are following one line with this graph. And if choline is raised, let us say, so the line is going to face downwards. So, this gives us a very good visual assessment. Now, we have to remember this. The good, the bad and the ugly. The good metabolite is Na, it represents the neuronal health. The bad metabolite is choline, it represents increased cell membrane formation and tumor. The ugly metabolite is lipid lactate, which represents necrosis, brain destruction and anaerobic glycolysis. And always remember, the creatine is always constant. Now, this also I want you to know very carefully, the brain metabolites which are seen on MRI spectrum and what they indicate. A lipid indicates products of brain destruction. A lactate is an end product of anaerobic glycolysis. Na is a neuronal marker and it is a reflection of the brain health. Glutamine and GABA are neurotransmitters. Creatine represents energy metabolism and is always constant. Choline is a cell membrane marker and Mi is a glial cell marker. So, let's talk about Na. It is the highest peak, it is there at 2.02 ppm and it is a marker of neuronal and axonal viability and density. Now, its absence or decreased concentration is a sign of neuronal damage, like in neoplasms and white matter diseases. Low Na may also be seen in leukodystrophies, MS, hypoxic encephalopathy and other diseases. Now, increased Na is nearly specific for Canavan's disease due to deficiency of aspartoacylase, which is an enzyme that degrades Na to acetate and aspartate. Now, Na is not demonstrated in meningioma or METs. Creatine. Creatine refers to total creatine, which is there at 3.0 ppm. Creatine and phosphocreatine. Now, it is always constant. Its level is always stable, and we can use it as a standard comparison to compare the other peaks. Now, we have to use this with caution because decreased total creatine levels has been observed in chronic phases of many pathologies, including in tumors. Now, this is choline. Choline is a peak at 3.22 ppm. It consists of total choline, consists of free choline, phosphocholine and glycerophosphocholine, with phosphocholine being the main component. Now, it is a metabolic index of membrane density and integrity as well as membrane turnover. Now, increase the total choline levels correlates with degree of malignancy. It also increases in infarctions, infectious diseases. So, we have to be very aware that its rise is non-specific. Now, we go to lipid and lactate. Lipid is a twin peak which is appearing at 0.9 ppm and 1.3 ppm. It is absent in normal brain and it may be seen in necrotic mets and primary malignant tumors. Lactate is a peak doublet at 1.33 ppm. The peak is again not seen in normal brain. It is increased in anaerobic metabolism, hypoxia, ischemia and many other diseases. So, prominent lipid lactate peak is seen in tuberculosis and toxoplasmosis. Mi appears at 3.5 ppm and it is a glial and myelin degradation marker. It is elevated in gliosis, in inflammation and Alzheimer's, and altered levels are also seen in degenerative and demyelinating diseases. Now, this is one more peak which is very important. Alanine peak, it has a doublet at 1.48 ppm. Now, it is a specific metabolite characteristic of meningioma. Now, you may ask that this is overlapping a lactate peak. So, how do I know this peak is not lactate and this is alanine? So, what I'll say is go back and see where I have placed the voxel. Now, in this voxel, there is an enhancing lesion that you can see. So this is most likely a alanine peak. If this was a necrotic tumor or a non-enhancing area, then this will represent a lactate peak. Now glutamate complex or left shoulder of Na. Now this is another peak at 2.05 and 2.5 ppm. Now they are major neurotransmitters. Glutamine is an excitatory transmitter. It is a precursor of GABA, which is an inhibitory neurotransmitter. So increased levels are seen in epileptogenic processes and also hepatic encephalopathy. Decreased levels are seen in Alzheimer's, dementia and chronic schizophrenia. There are several other peaks which are important. Glycine is there in glioblastomas, medulloblastomas, ependymomas. Taurine also is high in medulloblastomas, adenomas and metastatic renal cell carcinomas. Now this several other amino acids such as succinate at 2.4 ppm, acetate at 1.92 ppm, valine, leucine and isoleucine at 0.9 ppm together with alanine and lactate are major spectral finding of bacterial and parasitic diseases. Glutathione again is elevated in meningiomas. Now each metabolite appears at a specific ppm and each one reflects specific cellular and biochemical processes. All this I have already covered. So metabolite ratios. Now the common way to analyze clinical spectra is to look at the metabolite ratios, namely Na is to creatinine, Na is to choline and then choline is to creatinine. Now height of the choline peak provides a measure of how evil the choline is, just like the height of the bindi determines how evil the negative character in the serial is. So choline is to creatinine up to 1.1 is normal. Choline is to creatinine up to 1.5 to 1.5 is representing benign processes like infection, inflammation or demyelination. Between 1.5 to 2 it is indicating neoplastic and more than 2 is indicating a high grade glioma. So always you have to compare with the contralateral side or the normal side. Now common uses. Now these are the common uses of MRS in brain tumors, infections, multiple sclerosis, stroke, metabolic disorders and so on. And there is one mnemonic which is T-pride. Now MRS in brain tumors. Now MRS can be used to determine the degree of malignancy. Now as malignancy increases, Na is going to decrease and if the tumor is very bad, even creatinine will decrease. Now very hypercellular tumors will with rapid growth leads to elevation of choline levels. Lipids are found in necrotic portions of tumors and lactate appears when tumor outgrow their blood supply and start utilizing an anaerobic glycolysis. Now MRS is very important to distinguish abnormalities with same imaging appearances like tumor and radiation necrosis, tumor and abscess, METs versus primary tumors and lymphomas versus toxoplasmosis. Now multivoxel spectroscopy is best to detect the infiltration of malignant cells beyond the enhancing margins of the tumors. Now the key feature of gliomas is elevated intratumoral choline extending beyond the margins of enhancement, which is indicative of infiltration of tumor into the adjacent brain tissue. And high glycine or MI peak with low choline indicate oligodendroglioma. Now what is the pattern of brain tumors? As we can see, this is a normal MRS. The Hunter's angle is maintained and in tumors choline peak is elevated, creatinine peak is here, Na is down and we can also see the lipid lactate peak. So MRS of brain tumors may help in differential diagnosis, histological grading, degree of infiltration, tumor recurrence, response to treatment and differentiation between radionecrosis and tumor recurrence. Now this is a ring lesion we can see and we can see the edema. We have put the voxel on the enhancing part on the perilesional edema and another different area. So what do we get? We get high choline peak, Na is still there. There is little bit of lipid lactate. So this is not an infective granuloma. This is most likely a malignant lesion. Now MRS pattern of meningioma, we can see here there is a intraaxial enhancing lesion. So when we put spectro, what do we see? We see alanine doublet at 1.4 ppm, elevation of choline, lactate peak and absent Na at 2.0. So this is highly suggestive of meningioma. Now when we put a voxel between the peritumoral or perilesional edema in a GBM, what do we get? Again a high choline peak and a low Na with a little bit of lipid lactate. Whereas if we put it in edema of metastasis or any deposits, what do we see? The Hunter's angle is maintained. So this is a pure edema and this is infiltration. Now, MRS pattern of primary CNS lymphoma. Now, we can see there's a lesion which is placed in the periventricular white matter with diffusion restriction. Why? Because it is highly cellular. So, when we put the spectro, what do we see? We see a lipid lactate peak, we see Na is down, and choline is very high, and we also have a MI peak. Now, primary CNS lymphomas are difficult to diagnose, difficult to, to interpret when there is immunocompromised state or we have toxoplasmosis. So what do? We see the diffusion imaging. Toxoplasmosis will not be so enhancing. The second thing is when we can go in for the perfusion studies. Now, MRS pattern of brain abscesses. Brain abscesses destroy or displace the brain tissue, so Na is not present. Now, what are the potential abscess markers? As I told you, valine, leucine, isoleucine at 0.9 ppm, alanine at 1.3 ppm, acetate at 1.9, and succinate at 2.4. Toxoplasmosis and tuberculomas, they give prominent peaks from lactates and lipids. Now, in a pyogenic abscess, let us say if we place a voxel within the necrotic tissue, we don't expect any of the metabolites. What do we expect? Amino acid peaks at 0.9 ppm, a lipid lactate peak, acetate peak, and succinate peak, as we can see. Now, this is a typical picture of tuberculoma. Very high lipid lactate peak, even larger than Na. All the other metabolites are suppressed. Now, how do we differentiate NCC versus tuberculoma? In NCC, we can see a ring lesion, typically at the grade-wide interface with surrounding perilesional edema. When we put the spectro, what do we get? We get a lipid lactate peak. Na, choline and creatine are maintained. And what about this? We get a succinate peak at 2.4 ppm. So this is NCC. Again, in tuberculoma, it is a conglomerate lesion with perilesional edema, a very, very high lipid lactate peak. You can just have a look. So this is typical of tuberculomas. MRS pattern of hydrated. Again, we have put a voxel on the necrotic area or the cystic area. Now, what do we get? We get a sharp doublet of lactate, and rest all the other peaks are obliterated. Now, in tumor recurrence versus radiation necrosis, we know elevated choline is a marker of tumor recurrence. Radiation change generally exhibits low Na, creatine, and choline on spectroscopy. If radiation necrosis is present, the spectrum may reveal lipid and lactate peak, and whenever in doubt, do perfusion studies. So these are the two voxels that we have placed, one in the normal tissue, one in the perilesional edema that we can see. Now, in the normal tissue, we see all the peaks are maintained, and in this voxel, again, all the peaks are maintained. The only peak which is added is a lipid lactate peak. So this is most likely a radiation necrosis and not a recurrence. Again, we can do a perfusion study as well, where radiation necrosis will show low CBV, low CBF with slightly increase in choline creatinine ratio, whereas recurrent tumor will see a high CBV and high CBF with marked increase in choline creatinine ratio. Now, these are two similar looking lesions. Again, the same thing, very high lipid lactate peak here, and here also we get a very high lipid lactate peak. So, how do we differentiate? We go to choline. See the choline, it is raised over here in GBM, and post radiation necrosis, the Hunter's angle is still maintained. Now, important MRS use is also guiding the biopsy planning. So we have got a ring, we've got a densely enhancing lesion, heterogeneous lesion. Now, what is this that we can see? This is the tissue where the choline peak is a maximum. So if we take biopsy from this area, only then it is going to be positive. Otherwise, it can be false negative. Now, MRS pattern of childhood linked ALD. Now, there are symmetrical lesions in bilateral parieto-occipital regions. Enhancement of advancing edge is characteristic. And what do we get? Decreased Na and Mi and increased choline. So, the spectroscopic findings, even they come before what we can see the imaging. Now, in MRS pattern in Canavans, very classical, a very, very high Na peak, as we have discussed. Now, voxel placement in single voxel MRS studies of the brain tumors is critical to the accurate assessment and characterization of the lesion histopathology. This we have already discussed. So, MRS pattern of cerebral ischemia and infarction, markedly elevated lactate is a key spectroscopic feature of cerebral hypoxia and ischemia. MRS pattern of trauma. Now, in cases of trauma, we don't generally use it, but it is used to assess the degree of diffuse axonal injury. The presence of any lipid or lactate peak indicates a worse prognosis. Now, this is important. MRS pattern of some diseases, like in Alzheimer's, areas of hippocampal volume loss with raised MI peak and slightly decreased NA and elevated MIs to creatinine ratio. In hepatic NCAF, we get symmetrical T1 hyperintensities with raised glutamate GLX peaks. Now, a normal looking conventional MRI with comparative MRS of both hippocampi, if they reveal a smaller NA peak, at least 33% less, it indicates temporal seizure focus. In patients with melias, we get a lipid lactate peak, and in multiple sclerosis, increased choline due to active demyelination is seen with a raised lipid lactate peak, and presence of MI suggests severe demyelination. In HIV and AIDS, MRS distinguishes the common focal brain lesions. So this is this we all know what this is. It's a bifrontal lesion. Okay, we did a contrast study and a tracto for this patient also. So we can see here the fibers. Now why I'm showing you this is that we all know what kind of a lesion this is. So let's see what the spectro is telling us. So when we put the spectro, this is a normal and this is the abnormal area, and see this. The NA is normal. Peak is so high, and we get the comparative graphs like this. So in the abnormal area, we get the choline creatinine, which is very high, and MI peak also. So this is a high grade glioma. Now let's see some cases. Now this is the first case, a young female with seizures. We can see conglomerate lesions, perilesional edema. Now we put a single voxel over here. Now what do we see? A lipid lactate peak, another area, the different lesion, we try to track another lipid lactate peak, the Hunter's angle is maintained. So this is typical tuberculoma. Another case, a young male with altered sensorium, we can see a hyperintense area in the pons. Now the pons, as it is, has a very high choline levels. Okay, so look at where the choline levels are going, so high. Okay, another area, lipid lactate peak has appeared, and this is a typical pontine glioma. Now, similarly, heterogeneous lesion, a dirty looking lesion, we all know what it is. What is important is a lipid lactate peak, okay, along with a high choline peak and a MI peak. So this is highly aggressive lesion, okay, this is aggressive GBM. A ring enhancing lesion, we can see in the posterior fossa. Now, what do? We put spectro. What do we get? A lipid lactate peak, NA and choline creatinine, they are almost the same. So this is infective cerebellar abscess or a tuberculoma. Another case, young female with weakness in legs and numbness. What we can see is T2 or flare, hyperintense signals which are perpendicular to the ventricles. Some of these lesions are showing enhancement. We put MRS, and what do we get? Okay, NA peak is still highest, choline peak is slightly raised, and what do we have over here? Yeah, so this is a glutamine complex at 2.1 to 2.5 ppm. MI peak is also there, so this is demyelination. So this is typical multiple sclerosis active. So another young female with seizures, we can see there is a lesion over here. We put the spectro, and classical, a very, very high lipid lactate peak. This is what do we get? We get one more peak over here. Lipid lactate is high, but what is there? Okay, so this is succinate peak at 2.4 ppm, and this is likely NCC, this one. So to summarize, MRS is a non-invasive method of characterizing the tissues metabolites biochemically. Multivoxel technique is more complex but accurate. MRS is highly sensitive but sometimes non-specific, and always MRI is reported to be reported in conjunction with a conventional MRI. Thank you.